30 seconds of awkward silence while we're waiting. Okay, I'm just going to pop to Facebook. Make sure we are indeed
I forgot the
streaming.
lighting is okay, right?
Oh, yeah. You look great. Absolutely.
I know there's a little bit of a shadow. But...
No, that's totally fine. Okay, all right.
Okay.
We are rolling and people are joining quickly. We love to see it, so let's not keep them waiting. Ooh, I'm getting... 1 second. I was getting a little bit of an echo. There we go. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and a Neuroendocrine Cancer Foundation program. By the way, if you weren't aware, LACNETS is now rebranded as the Neuroendocrine Cancer Foundation. So that is the name that we will be using moving forward. And I've worked with both of these organizations for quite a bit of time. My name is Rain Bennett. If you don't know, I'm your host this episode and every episode. And my background is in filmmaking and writing. And so I first started working with CCF over 10 years ago. I think it was 2011 or 12 to create video content. And we have continued to do that, all different kinds of video content over that decade plus, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. Now, the value that I really see here on the show is twofold. One, absolutely the information, hopefully question or answers to your questions you'll get from our guest. And two, the shared experiences and the shared stories from within the community. That is something that I have seen firsthand working alongside the NET space, NET community, is how powerful and supportive that community is, whether it's patients, caregivers, providers, support group leaders, everybody. It's really amazing to see. So if you're new to this journey or new to the show, you can see people saying hello and introducing themselves. I encourage you to do the same thing. Tell us where you're signing on from. Reach out. Embrace the community. I will assure you they will embrace you back. It's a beautiful thing that I've seen. Before we get started, we want to thank our presenting sponsors. We couldn't do the show without them, so special thanks to them for their continued support. We've been doing the show now for 5 years. I mean, we started in 2020 because of the pandemic. So, hey, that's saying something. But I am happy to welcome to the show for, I believe, the first time, Dr. Delphine Chen. Is that right, Dr. Chen?
Yeah, my first time.
Well, welcome. We're excited to have you. So for those folks who may not know you and the work that you do, some of our guests already do because they're saying hello to you specifically. But if they don't know, let us know where you work, what you do, and the role that you fill in that community that I mentioned.
Thanks. Well, again, thank you for the invitation to be on this. And it's great to see some of you who I know in the audience. So thanks for saying hi. So I'm Delphine Chen. My background is I'm a nuclear medicine physician, and I work at Fred Hutchinson Cancer Center and University of Washington. I have my official title is Director of Molecular Imaging and Therapy. So I'm over the clinical therapy and diagnostic services and nuclear medicine services at Fred Hutch. I also hold responsibilities over our radiochemistry program. So in terms of developing new radioactive drugs for cancer imaging. And my clinical expertise is in all things related to cancer and nuclear medicine. So that includes, everyone knows about PRRT, dotatate PET, that's specific for this audience, and other modalities that we use across the board for cancers.
Just for the folks at home, how comfortable is there any other topics other than imaging, radiology, things like that you're comfortable fielding, just in case we get questions or people that sign on later?
Yeah. So my expertise is in nuclear medicine. So where I'm going to be best able to address questions are on the imaging or therapies related to nuclear medicine. I may be able to answer some things with regards to, we interact a lot with medical oncology. So I won't be able to answer like medical oncology questions per se, but I can share some of our experiences on those interactions too.
Awesome. Thank you for letting us know that. That's one of the things, back to my point about the community is like, I always like to ask that because even if it's not your area of expertise, so to speak, so many net specialists work together with each other. They know a lot about this. It's very specific to disease.
And I was going to say it's across all the specialties. I obviously call out medical oncology because that was like the primary, when we were setting up the service, that was our, first and foremost partner in setting it up. But obviously, interventional radiology, radiation oncology, surgical oncology, endocrinology, and there are other specialties as well that we're
Sure.
interacting with too. So
Yeah. Well, you'll
yeah.
be happy to know that we get lots of those types of questions every week anyway. So
Oh, great.
be prepared. Yes, the common topics. And for folks at home, just a little bit of best practices. If you're familiar with the show, you know what I'm about to say. It's very hard to answer case specific questions in this format. I mean, especially if Dr. Chen is not your doctor, but even if so, the best way to get the answers to your questions and the guidance that you're looking for is just small generic chunks. There's no limit to how many questions you can ask. If we need, or Dr. Chen needs some clarification and you're still on the call, we may ask it like, hey, Tom, can you clarify this? But long, lengthy chunks of text aren't always helpful, but just in this format. So smaller bits and continue to ask follow-up questions. And of course, one of the great things that CCF and the Neuroendocrine Cancer Foundation has established is the support line, and we'll try to put a link to that. It's already in there. Look at that, ncf.net/support line. Thanks very much. You can always reach out for follow-up questions there in between the episodes that we have, which are every 2 weeks. I wanted to say a little shout out to, who was that? Iram. Let me know if I pronounced that correct, from the Philippines. I believe that's the first time I've seen your name here, so welcome. We love to see how far these programs reach, especially live. And I know in the Philippines it's what, midnight right now? So yeah, really appreciate you being here. Shout out to Rachel over from YouTube from Western North Carolina. I'm assuming that's what WNC means, and hope you all are doing well with the efforts to get back to some state of normal after the hurricane. A lot of good friends from there. So go ahead and start sending in your questions. We will get to as many of them as we can. Sorry, Rachel, it's up in the comment section. It's the link is up there if you scroll up, and we'll continue to provide those links. If there's anything Dr. Chen mentions today, resources, studies, or anything like that, we'll try to populate the comment thread with those links so you don't have to go open up another web browser and try to search for that while you're trying to pay attention. Okay, let's go ahead and get into the show. We've got some questions coming in already. So first one comes from, and I'm really excited about our group, our growing group over there at YouTube. Sorry, Rochelle, I hear you. We initially started this show off only on Facebook, and so we've implemented YouTube, I believe, last season, and it's been nice to see that group growing ever since. So Denny says, if a patient has progressed after retreatment with beta PRRT, is there a situation where you would recommend alpha? And if you don't mind, Dr. Chen, let's establish what those are for someone who might not be familiar. Yeah.
Yeah, absolutely. So everyone has probably heard the term PRRT. When you join the neuroendocrine tumor community, that is one of the common treatments that we use for metastatic disease. It stands for peptide receptor radionuclide therapy. And it's basically the delivery of a peptide that targets the neuroendocrine tumor with our clinically approved Lutathera or lutetium-177 dotatate that targets the somatostatin receptor, and it is a peptide with a radioactive label. So I'm going to use PRRT because it doesn't always have to be lutetium-177 dotatate. So there's Y90 as the isotope, and also DOTATOC is used, and several other different peptides that can be used, and those are used internationally. So in terms of the specific question about beta emitter versus alpha emitter, so lutetium-177 is a beta emitter. So at least within the US, lutetium-177 dotatate is FDA approved, and that is a beta emitter PRRT. So what that means is that the energy emissions from the radioactive drug that kill the cancer cell are beta emissions. And the difference between a beta and an alpha emission, because an alpha emitter is similarly a radioactive isotope that also emits an alpha particle instead of a beta particle. And so the difference between that is that the alpha particles are much larger and they deposit a lot more energy within the cell in a shorter distance. So if you imagine a cell, like say this is a cell blown up, and you have a beta emitter, the beta emissions can go kind of in this relative to the cell. It's kind of a long travel length. But passing through the cell or getting deposited, it'll kill it. An alpha emitter, it will deposit itself all within the cell because it travels only like this long as opposed to this long, as it just is relative, concepts. So when we talk about beta emitters, because people in the US at least, and certainly those who have been treated with the lutetium drugs abroad as well, you can get disease control, but then a good number of people progress eventually. And then some people get a second round of treatment with the PRT. In the US, that'd be most common with lutetium-177. Internationally, that could be with potentially other emitters, probably most commonly still with lutetium-177, and that's probably the largest experience with retreatment has been with lutetium-177 dotatate. So you're using these beta emitters and you gain some more control even after that retreatment. What happens then after? And so there have been case reports of patients who have then received an alpha emitter PRT. And this has been investigated also in prostate cancer. So there was I think, a very well-known case publication where a patient who had been treated with lutetium-based prostate cancer targeted therapy they were treated with an alpha emitting targeted therapy for prostate cancer, and they had a marked response, like all their disease went away. So there's a lot of enthusiasm and hope and maybe a little bit of hype around alpha emitter PRT, because the potential is if we can get that energy delivery targeted to the cells, if they didn't respond to the beta emitter, perhaps they would respond to the alpha emitter. So I know that was a lot of background, but that's a lot of context in terms of where alpha PRTs are, because they aren't approved in the US yet. So the only way, at least in the US, the only way you can get access to that is through clinical trials. And there are a number of clinical trials going on, including actinium-225 is one of the isotopes you'll hear about most commonly. Lead-212 is another one. And those are in various phases of clinical trials and clinical development. In terms of, so when I'm answering this specific question, I would say that we don't have the data yet in the US particularly. And I would say even looking at the literature broadly, I'm not sure there's a clear set of criteria that you can use to say when you would recommend a patient to go on to the alpha emitter PRT versus other drugs that would be available for treatment after retreatment with the beta PRT. I would say all of that is being done in clinical trials right now, as I mentioned. So if you meet the clinical trial eligibility, you can kind of get a sense of where they're feeling it's safe and most likely to have a benefit or a signal, like a response, an actual response in patients when you look at the clinical trial data. And many of some of these clinical trials will look at patients after they've progressed through all standard of care therapies. Others have varying levels of, exclusions. Can you have had prior PRT or not? So that you can see based on that clinical trial data, on the clinical trial eligibility, there's not a clear answer to say exactly who, because we don't know precisely who is going to be the best responders to the alpha emitter PRTs. So long-winded answer, Denny. Appreciate that question, because I know we've had some conversations in several other forums and offline about that, and I know it's a big topic and open question, and unfortunately, we're still doing clinical trials, and that's where we're at right now.
Got it. Thank you so much. And thank you, Denny, for your question. And by the way, Dr. Chen, we like long-winded. We call it thorough here on the show. And it's really helpful because I always, a lot of and I'm sure you know this with NET patients, a lot of our community here is very well educated. They know their stuff very well, but there's also people that join every week that were just diagnosed. And so I always like to make sure that we lay that foundation for those people who are new to this journey, who are confused, and that's very helpful. So I appreciate you for that. Okay, moving on. A question from Charles, kind of a big question. So maybe more about what you've seen in your experience. How often would you say that NETs metastasize? I know that's probably a loaded question.
Oh, yes. And because I will be honest, I don't know the exact numbers that have been reported in the literature off the top of my head.
Right.
But that has definitely, I know that has been described, and it does vary by where the source is. Like when I will say from my personal experience, it's always going to be biased by who gets referred to the nuclear medicine clinic.
Fair.
Or who we see in neuroendocrine tumor board. So I can't say definitively, so when I think about how often they metastasize. That was the question, right? How often
Yes.
they metastasize. So I think about it in terms of where in the journey of the neuroendocrine diagnosis and treatment are you? So in the very initial staging phase, like they've just discovered your neuroendocrine tumor, or they went in and did a surgery. Sometimes some of these are identified just incidentally. They went in to take out the appendix for some reason, and then they found a small neuroendocrine tumor. Or so when you're at that diagnosis stage, the likelihood of metastasis is driven by how large the tumor is, whether we see abnormalities on imaging. Some of these very small tumors that are found incidentally, probably very low likelihood of metastasis, like if it's considered a grade 1, completely resected, or it was found like on an endoscopic biopsy and gastric, when we know that it's a small tumor that's we're confident is completely resected, it's probably very unlikely that you'll have metastasis. Once you get to the larger tumors, and you start seeing nodal metastases or liver metastases, again, in that initial diagnosis or initial staging phase where you either just had your surgery or you just had your initial imaging, obviously then we see a good number of metastases. But if you're able to resect it all, this reason we look at surgery very early on is that we could potentially cure it. It's to functionally cure it. There's probably no definitive, oh yes, you're definitely cured, but we do see patients who, if you can clear the majority or all of their disease, they may remain disease-free for the rest of their lives. So whenever we can do that, we think about that in the initial staging phase. Once, say you've got your tumor completely resected, it's a larger tumor, you didn't have any metastases then. Now the question is, what is the likelihood you'll develop metastases later after a complete resection? That is also somewhat variable, but obviously there's a higher rate of metastasis when you have larger tumors. And depending on where it's located, depending on if it's pancreas or GI or lung, your oncologist will make specific recommendations based on what the pathology shows and what the expected level of aggressiveness of that behavior is, and how much you'll and sort of dictate the imaging that way. I would say in that bucket, then it's a little harder for me to put a number on. And as I said, I don't know the numbers from the literature off the top of my head, but I do think it's because of that higher concern for the recurrence that a larger number of those patients will develop metastases over time. I hope that answers the question.
Well, yeah, I mean, I
It's a
thought I
very
think it was
big
a
one.
great answer. Right. Well, I mean, that's why I still like asking those questions that certainly don't have a specific and direct answer, because it still provides a great opportunity to discuss the overall question behind the question, if you will.
Yeah.
So yeah, you can't say like, oh, 67% of the time, but it allows what you did, which I thought was great, to just walk us through that staging of it. So thanks. And thanks, Charles, for your question. Let me know if it helps, or of course, if you have any follow-up questions. Next question comes from Carrie. In your opinion, what is more important, avidity or growth on a PET scan?
Yeah. So a PET scan is best able to assess avidity first and foremost, but you can assess growth. And the reason I put that caveat there is because what you see on a PET scan depends on how much of the tracer that tumor takes up. So if you say you have a 1 centimeter tumor, on one scan, that 1 centimeter tumor might take up what we would say a mild to moderate amount. So that means the uptake is, you can see it above background, but it's not something that jumps out as, wow, that is super bright. And that same 1 centimeter tumor on a different PET scan could be super bright. Like you just immediately, as soon as you look at the scan, you just see it stand out across everything else there. So when you have those differences in intensity of uptake, you can get this apparent difference in size. So those really bright tumors, the ones that take up a lot of dotatate, can look bigger than the ones with lower uptake. And that's because of the brightness, and that's how you window, and that's part of the specialty training within nuclear medicine. How do you appropriately window those PET images to be able to assess for changes in uptake intensity? That said, though, you can also sometimes see size. So if you have a 1 centimeter and a 5 centimeter lesion on 2 different scans, and they both have a lot of uptake, then you can see that it's gotten bigger on the PET. But what you do is, PETs are never done in isolation anymore without either a CT or MRI. So we always do them on a PET CT scanner or a PET MR scanner. And so the CT or MRI information from that scan helps us look at what that size is, and whether there's a true anatomic change in size. So we will always look at those two things together in terms of when you're interpreting a PET scan. So we'll ground the appearance of the PET in terms of growth, we'll ground that in the anatomic imaging to confirm. But obviously, even if, because sometimes we get outside scans that are hard to transfer. I think, unfortunately, all of us in the healthcare field have experienced this. If you move to a different medical institution, sometimes those images are just hard to transfer. So sometimes I am looking at PET images without the CT because we couldn't get all the CT images. And so sometimes you can see those changes in size. But I would say the standard of care when you're interpreting a PET is that you look at both the intensity and size changes and you ground the size changes in what you see on the anatomic imaging.
Got it. Thank you. Next question from Ron, sticking with the PET scan. How many days should I wait after receiving my monthly octreotide injection and getting a gallium-68 dotatate PET? Will it affect the accuracy of the PET image? I've read it affects the PET scan image, and I have read that it does not. So he's a little bit confused. Is this something to be concerned with in scheduling my next PET scan?
Yeah, that is a great question. I think we've had a lot of conversations as well in the field and with our patients, because there is, when we first started doing dotatate PET scans, the recommendation was that we don't do the PET scan at right after any somatostatin analog injection, because the concern was that the somatostatin analogs bind to the same place as the dotatate, and that might compete with the dotatate and give you a false negative scan. So the interesting thing is that when you look at, actually, these were publications from other centers in Australia. Like Australia is the one that the largest series I think that I can think of off the top of my head, but there are at least two other publications showing the same thing. They showed that if you do the dotatate PET scan within a week or two, so that would be considered a short time after giving a long-acting injection, you will actually see increased uptake in the tumors and a decrease in background. So that actually increases your sensitivity of the dotatate PET scan. And so some of these recommendations to not do the PET scan if you've just had your somatostatin analogs, like we have in our internal conversations, we decided that based on the available literature, we don't see that the somatostatin analogs are interfering with the quality of the dotatate PET scan or our ability to see the uptake in the tumor. And therefore, we do not enforce any specific time point when after a somatostatin analog injection, when you have to wait to get your dotatate PET. So we are willing to just do that whenever, because it's possible that you actually might get a more highly sensitive PET scan if you do it closer to the time that you've had your somatostatin analog injection. But that is, like I said, these were single center studies. So we don't have, a wide swath of unselected data, unselected patients like we see in our clinical practice. But based on that, we do see that fairly commonly too in our patients when we're reading follow-up dotatate PET scans on someone who has started their somatostatin analogs. So just the fact that you're on the somatostatin analogs, when you look at your baseline dotatate PET compared to, say, you get another one a year after you started, you can see the difference in the background. The background is lower on that scan that was done while on the somatostatin analog. And then sometimes you can see more lesions. And then that does create this, do you call progression or not? And that's why we look at the anatomic imaging very carefully, because sometimes you can verify that actually those lesions were all there before. And it's just that now that you have the somatostatin analog on board, you actually see the tumors on the PET. And sometimes when you see that, also you can look backwards and say, oh, looking in retrospect and putting them together, there may have been subtle uptake in the liver. That's probably one of the most common areas where we might not see the uptake as well, because the liver has high uptake on the dotatate PET. But when you go backwards and see, then you see this pattern that matches what you see on the scan where you clearly see the tumors. And then you can sometimes say, oh, actually, in retrospect, all these areas of uptake that looked like noise on the image could have been actually small neuroendocrine tumors. And that is just, we see that pattern fairly commonly with the low-grade neuroendocrine tumors. So, but it just speaks to the fact that there's not really, I'm not aware of any good data to say, like, this is exactly when you should get a dotatate PET scan after, you get your somatostatin analog injection.
Got it. Thanks, Ron. Appreciate you and your question. Next question comes from Eileen. Is there an SUV number on the gallium-68 that qualifies you for PRRT or an SSA, somatostatin analog?
Yeah, great question. And I know SUVs, or standard uptake values, are a commonly discussed topic for PET because we all like numbers and like we all like numbers to track things. And unfortunately, the SUV it's a little harder to know what to do with the SUV changes on a PET over time because they don't necessarily mean those changes in SUV don't necessarily correlate to a change in tumor biology or a change in the aggressiveness or even a change in the tumor itself. So, but that said, SUVs have been investigated quite a bit for looking at whether someone is eligible for PRRT. It's used less for somatostatin analogs, and my understanding on that is because when you look at the clinical trials showing that there's a benefit for treating these neuroendocrine tumors with somatostatin analogs, they didn't use dotatate PET for selection. And we know that most of these tumors generally express somatostatin receptors. So we do not routinely use dotatate PET specifically to assess whether someone should start on somatostatin analogs. We do occasionally use that information for lung carcinoids because the uptake in lung carcinoids is more variable. With GI neuroendocrine and pancreatic neuroendocrine tumors, they nearly always, the low grade GI and pancreatic neuroendocrine tumors, are nearly always very dotatate avid with few exceptions. With lung carcinoids, it's more heterogeneous. So more of those might have lower level uptake. So we will sometimes use the dotatate PET to say, okay, in this case where there's a lung carcinoid and we're trying to figure out what the next option is, this may add a little more information to say, okay, we might start with somatostatin analogs first instead of another treatment. But we also don't do that routinely. It's just occasionally when it comes up and if there is some question about whether somatostatin analogs should be started. So finally, with the SUV cutoff for PRT, as I said, there's really no cutoff for SUV. Everything is based on a version of the Krenning score. So I think all of you have probably heard about that. It was really developed to characterize visually how much uptake was in neuroendocrine tumors in an Indian 111 Artria scan. That has been, of course, since extrapolated to PET. We haven't, it's whether we need prospective data to test the validity, I'm not sure, because it's a helpful, regardless of that data, regardless of not having that data and how you specifically use it for PET. We do have data especially from NETTER-2, they did use dotatate PET. Just, NETTER-1 actually did not use dotatate PET. So just to clarify, but we extrapolate from the criteria from NETTER-1 because we know dotatate PET is more sensitive than Indian 111 Artria scan. But from NETTER-2, they used a threshold of like liver and above to, I think, actually above liver to qualify for treating. In clinical practice, we generally will require at least uptake above the liver on the dotatate PET scan or any somatostatin receptor PET scan. But we will sometimes accept patients who have uptake that's similar to liver because that's still much higher than background. So that was why in clinical practice, it's a little bit of a moving target, but it's generally based on the visual assessment. And in general, we prefer having the much higher uptake above liver because those patients tend to respond better.
Got it. Thank you. Appreciate it, Eileen. Next question comes from our friend in the Philippines, Iram. Let me know if I'm pronouncing that correctly. My partner's diagnosed with PNET, Ki-67 3.8, head of the pancreas. His first line of treatment was PRT, just finished it last June. After a 3-month follow-up of PET dotatate, said it was stable, and then our nuclear medicine doctor suggested to follow up PET dotatate after a year. The question is, I would like to ask if how long does PRT make the patient stable, and is there any side effect for PET dotatate? So a couple questions in there.
Oh yeah. So in terms of the progression-free survival, you can. I'm not going to quote the data off the vision trial. Again, those numbers are not, I should have those numbers, Pat, at this point, but I apologize. I'm always like, I always check the literature to make sure I'm not confusing my numbers. We clearly see an increase in progression-free survival, though, up to like, I think, a year's difference in terms of number of months of progression-free survival in that range when you look at the NETTER-1 trial data. I would say in clinical practice, that degree of control has been variable, that what we observe is variable. And so what we usually look at is the baseline dotatate PET to try to predict, okay, which of these patients are going to do better. But in the end, we follow everyone with CT scans or dotatate PET scans after PRT to document exactly how you do on an individual level. So in terms of the expected benefit for PRT, we're really hoping that most of our patients will have at least a year, because that is, that is very close to what we saw sorry, I probably said vision trial. This is the problem with having we are big radioactive, theranostic practices are in prostate cancer and neuroendocrine tumor. And for a while, I think everything got switched to PSMA and prostate cancer. So I apologize about that. For NETTER-1, when you look at the progression-free survival curves, you can see that clear difference. And that's really what we're hoping for most of our patients. In clinical practice, I'm not really sure if we see that degree of control, mostly because we're not following the inclusion criteria for those clinical trials. Like I said, we accept more patients who maybe have more heterogeneous dotatate uptake, because sometimes because of that clinical situation, there may be reasons why you don't want to pursue chemotherapy or one of the other targeted therapies. PRT tends to be very well tolerated, and sometimes for those patients who have other health conditions, we choose to do PRT first to see what kind of benefit we can get before we have to move on to something that's potentially more toxic, or something else that potentially has what we see in clinical trials as a shorter range of disease control. But I want to caution that when we're comparing those different studies, we don't have a head-to-head study comparison. Those are ongoing, like head-to-head studies looking at everolimus versus PRT. And there was another trial that, unfortunately, there was another head-to-head comparison with CAPTEM, I think, unfortunately, that closed early because of lack of accrual. So as a side note, when we don't get patients who are willing to participate in our studies, that does make it a little more challenging for us to generate the data to say for sure, okay, this treatment is better than the other. So that's my small plug for clinical trials, which I think this neuroendocrine tumor community is very well aware of, in terms of our need for trying to generate data to help inform these responses. But back quickly to the question. So that's what I have to say with regard to the potential length of disease control after PRT. And in the end, on an individual basis, we just have to get scans and see how you do. In terms of the toxicities from dotatate PET, we are not aware of any. So the radiation exposure is fairly low for that and any CT scan that you get. What patients are usually concerned about is the cumulative exposure, because usually you are going to live with this disease for a long time, and you potentially will get radiation exposures from all the imaging that you get. So there are some retrospective data to see what is the impact of medical imaging radiation exposure, and some of those have identified a very small increased risk of cancer in a non-cancer population. Because what we're worried about with radiation exposure is, are you going to develop a cancer as a result of the radiation exposure we're giving to you? And that's a bigger question for patients who don't already have a cancer diagnosis. When you already have a cancer diagnosis, usually the benefit of that information outweighs the risk of the radiation, because if we don't have the information from the imaging, we're not going to know how to best manage your cancer. And that very small potential, and again, it's unclear, but if there is any potential addition to that cancer risk from the radiation exposure, it's going to be very small and very difficult for us to measure. Okay, so I hope that answers that question. But yeah, the plug for clinical trials, it was a little sad to hear when we saw that one clinical trial close when we were trying to get some data to look at the comparator arms. And I understand it's challenging because it's not that exciting to participate in a clinical trial that's looking at some what we consider standard of care therapies. But we know from past experience with other treatments, like if you don't do that head-to-head comparison, you may not actually see what the true difference is. And there have been some treatment regimens in the past that where one was prescribed over the other because of individual trials independently looking at them against placebo or a different comparator arm. But then when they did those trials together and compared them head to head, there was actually no difference in terms of the benefit of one versus the other. So
Got it. Thank you. Folks, we are just a little bit past halfway in today's Luncheon with the Experts program with our guest, Dr. Delphine Chen. This is a CCF and NCF production, and a special announcement. Today is actually World Storytelling Day, which is how I make my living. But why it's important to you is because storytelling is how we communicate as humans. And so even in a question and answer format like this, Dr. Chen, you'll hear that she uses stories to express, or go deeper, explain something to you or give that information across. So we use storytelling to get information across, and we always have since we lived in caves, and that's how we establish connections and trust, and therefore we're able to build communities like the net community, like the community we have here at the show. So storytelling is embedded in all of our lives, but especially so in this community, how we share stories so that we can all move forward together. So in that note, happy World Storytelling Day. And I believe it's the first day of spring at the same time. So
yeah,
little bit of trivia there for you. Let's continue on with Luncheon with the Experts. Our next question comes from over on YouTube again from Sarah. Sarah says, what is the status of and the future for immunotherapy with PRRT?
wow. Okay, that's a really good question because we don't have a lot of data in that space yet. We do have, I think, case anecdotes. Like I know we have one patient who had a phenomenal response to the combination of immunotherapy with PRRT. There is one other case report at the time, and there are other clinical trials that are being in development, I think, or on either they're open or under development that I'm aware of. And so I think that story is an open one still. I don't think we have enough data to say exactly who are the right patients to treat with combined immunotherapy and PRRT. I'm less familiar with trials about immunotherapy specifically, so I'm not going to be able to comment on the state of immunotherapy as a sole modality for treating neuroendocrine tumor. But as you're aware, it's a modality that's being investigated across all the solid tumors, because we have had such phenomenal responses in, cancers like metastatic melanoma, where the mortality rate was quite high, and now patients are living for so long because of the outstanding responses to immunotherapy. So, but it's an open and evolving space, I think, for a neuroendocrine tumor.
For sure. Thanks, Sarah. From John, are there ever any neuroendocrine tumors that are only borderline malignant or pre-malignant? Mine was found incidentally. I had 0 symptoms. Ki-67 was less than 1%, although it was 3.3 centimeters.
Oh, yeah. So I'm not aware of any pre-malignant lesions. So we do have different terms for that when it's a lesion. Like one of the examples is Barrett's esophagus. So the Barrett's esophagus describes changes in your esophagus that tends to be a precursor for the development of esophageal cancer. But not everyone who has Barrett's esophagus gets esophageal cancer, but we do see it commonly. So I personally am not aware of anything like that for a neuroendocrine tumor. In terms of the malignant potential, so it is still considered malignant. The interesting, I guess, aspect of the biology of neuroendocrine tumor is that with it being well differentiated, the well differentiated versus poorly differentiated or moderately differentiated, you will see those terms applied to cancers in general across the spectrum, like for other GI cancers as well. And that does give a descriptor of how much does that neuroendocrine tumor look like normal cells, and how much is it likely to behave like a normal cell versus a really aggressive cancer cell. So as you can imagine, cancers that are poorly differentiated mean they don't look very much like their cell of origin, whether it's lung cancer or GI or other. And so they tend to be more aggressive and grow faster and cause more problems. And so we get more worried about starting the treatment right away with poorly differentiated. With well differentiated, because that means it has some features that look like the cell of origin that it came from. That's why they tend to grow more slowly across the spectrum. So you look at all the cancers, the well differentiated ones, regardless of the source, they tend to be more indolent in their growth. That doesn't mean they won't grow. And it doesn't mean they won't metastasize. So unfortunately, even though it's low, it's considered a low grade tumor and not less aggressive in biology, that doesn't mean it won't eventually metastasize. When you have something that's like a larger lesion, like a 3 centimeter lesion, and that Ki-67 is low, that Ki-67 index means that less than 2 or 3% of those cells are proliferating or actively dividing. And it's those actively dividing and proliferating cells that cause the tumor to grow. So what that means is that at any one time, that tumor has like less than 2% of cells that are actively dividing and growing. So that kind of is another metric of characterizing that more indolent, slower growing behavior. And so that just means that the expected biology of that type of tumor is that it will, if it comes back at all, it will come back very slowly. And if it does metastasize, you can definitely see metastases come up, and it will look like they just suddenly popped up because you're getting your scans at a certain rate. And so you're not able to see, exactly what's happening with those tumor sites within each scan. And so I think from both imaging and even a patient perspective, when you see that, you'll see this thing that says new metastases. And it's like, oh, did they suddenly go from 0 disease to now I have 20 tumors? And does that sounds very aggressive, and that can sound really scary and like, oh, that's are all new. The challenge is if you see that kind of behavior with a low grade tumor, first we will rebiopsy to make sure it's still that low grade, still make sure it's a Ki-67. But depending on what the length of time is between those scans, if it's a longer duration, sometimes it may be that we just couldn't see those other sites and they have just been slowly growing. And then they finally got to the point where we could actually see them on imaging. So that is another possible explanation. So it's a bit of a nuanced question in terms of when you're trying to talk about malignant potential. And that is why imaging surveillance is a core part of monitoring neuroendocrine tumors, and also why the frequency of the imaging recommended varies depending on what that initial histology is and the expected biological behavior.
Got it. Thank you. Next question from Brent. Will bone mets show up on a PET scan?
They will if they take up the dotatate. So, and I would say those low-grade GI neuroendocrine tumors, we almost always will see those bone metastases if they are there. In the rare circumstance where the tumor doesn't take up that much dotatate, then we probably won't be able to see them. So it's all dependent on how well that tumor takes up the somatostatin receptor, or how well it takes up the dotatate PET.
Got it. Thank you. Thanks, Brent. I'm not sure if I've seen your name before, so if you're new to the show, welcome. Appreciate you being here. Next question from Rochelle. Got it right that time. If I was diagnosed with gastric carcinoid / NETs in December 23, and they did a PET / CT scan in March of 2024, why would they only do a CT scan March 2025?
Yeah, so we have a similar practice, like where we don't always use dotatate PET scans. We are trying to balance the amount of radiation exposure we're getting, because even though what I said about radiation exposure, if you need the scan, you need the scan, and so we'll go ahead and get it. But at the same time, we're trying to manage, like, how can we best get the information we need to decide what to do next without giving you too much radiation exposure that you don't need. And so because dotatate PET scans can have those variabilities in SUV and other things that can sometimes cause confusion, and we generally ground our treatment decisions on how much the tumor is growing on the anatomic imaging. That's why usually we rely on anatomic imaging for following most neuroendocrine tumors. So whether it's CT or MRI, we tend to use dotatate PET more selectively. All of these are expensive tests, but dotatate PET is an expensive test. Its availability is sometimes limited in certain areas as well. And dotatate PET is really helpful for when something changes on the CT or MRI, then we get the dotatate PET. So that that is a common strategy I've heard at a number of different neuroendocrine tumor, high volume neuroendocrine tumor centers, where they get that initial dotatate PET to say, okay, this is where the extent of disease is. And if we see things that are going to be hard to see on CT and MRI, we will consider then doing the dotatate PET and subsequent surveillance imaging visits, but that we don't tend to do it as much, like unless there are lots of bone metastases that we really can't see on the CT, and that doesn't happen very often. Usually the CT and MRI, like once you've established the extent of disease with the dotatate PET first, usually a CT or MRI is sufficient for following, and so then we can manage that imaging related radiation exposure and try to maximize the data we get from that while minimizing that exposure, and then use dotatate more selectively.
Got it. Thank you so much. A question from Mara, back to PRRT. It's a bigger question, but in general, she says pros and cons for PRRT, which I know we've talked about a little bit already. But then also more specifically, how many are considered max can we have? And I know that number has changed or is changing currently, at least in the US.
Yeah, that's the number of maximum cycles, right? Or number of treatments you can get.
Yes. She doesn't specify in the question, but that's what
Yeah.
I'm led to believe. Yeah.
Okay. Yeah, that's my understanding too, based on what you're saying. So there is no specified maximum number of cycles you can get from a pure clinical tumor treatment management perspective. So if we think it's going to give you benefit, that we would recommend that, assuming that your marrow reserve is okay, your liver is doing okay, your kidneys are doing okay, and you don't have other issues that we're worried about with causing toxicity. And when you look at the literature from outside the US, there are patients who've gotten, 9 or more cycles of PRT in various forms over their lifetime. In the US, the other component consideration, of course, is the coverage. Like, is your insurance going to pay for it? Because in some countries, they will pay for it as long as the physician thinks it's the right next step for that patient. In the US, of course, we have what we have. So in general, we have been able to get, at least within Washington State, I can say we've generally been able to get additional cycles of the PRT approved. So I can't speak to what that looks like in other areas of the country, because as we know, insurance coverage can vary somewhat locally. But in general, I think that my impression is that it is possible to get those additional cycles approved if there is a strong justification. And particularly, we tend to do even more cycles beyond. So the standard retreatment protocol is you get your initial 4 cycles, and then you might get 2 more cycles after that as part of your retreatment protocol. We have not tended to give additional retreatment protocols after that. Not as many cases, I should say, have been reported in the literature on the outcomes of getting even more cycles than that. But usually when we think about that, when we're thinking about those retreatment protocols, we are looking at, is this the best treatment right now? Are there other treatment options? And if we're limited, especially once you get beyond you've got your first 4 cycles, you've gotten your next 2 cycles, and now we're thinking, do you need another 2 cycles? There are various, depending on the clinical situation, obviously, if we think that's the next best thing, that'll be documented and that'll be submitted to insurance, and then we'll do our best to get it covered. But that's always an open question, because I can't say those always get covered.
Got it. Thank you. Appreciate your question, Mara. From Debbie, I had a lobectomy on 11 millimeter net in October 24. I had clear margins and am stated cancer free. That's great news, Debbie. The question is, will I have scans throughout my life? So I guess it's more of a follow-up question.
Yeah, probably. I would say, and I will say I'm less familiar with this, what has been published with surveillance for lung neuroendocrine tumors or lung carcinoids. I will say I'm much more familiar with some of the recommendations for GI neuroendocrine tumors, just because I recently had to put that together for a talk. So had I known, I think this is a question I'll just look into, just to sort of update my own, my own like assessment of the literature at the moment. But in terms of the lung neuroendocrine tumors, yes, imaging is a core component of following you to see if it comes back. In all likelihood, you probably will have scans the rest of your life. But what tends to happen is that as you get further and further out from your surgery and you continue to be disease-free on imaging, those scans will get spaced out because you don't need to have scans every 3 months for the rest of your life to just prove that you're disease-free. So, and especially the fact that if you usually scans will be obtained more frequently earlier, because when we see recurrence, it tends to happen within those first few years or so. And once you've demonstrated that if that disease is not coming back within that time, that suggests to us that the biology is probably more indolent, and then you can space out the scans. So I will say, with surveillance imaging, I feel like even with the data that I did look in GI neuroendocrine tumor, there is no strong data to say exactly what the right surveillance imaging frequency or program is. So even when you look at the GI neuroendocrine tumors where we have a good amount of information, there are, if you look at ENETs, NANETs, NCCN, like ESMO, all these different guidelines, they all are a little different because they're all expert consensus panels. So that's why in the end, for an individual patient, we always look at it as it's going to come down to a conversation with your oncologist or your surgeon or your endocrinologist, whoever is following you for your neuroendocrine tumor, in terms of that personal discussion on how to do the surveillance. And each practitioner is going to have, it may vary in their recommendations based on what that local experience is, or like combining local experience, data, and your personal considerations. So it's a very personalized decision in the end.
Absolutely. Got it. Rochelle asked a question about the best places to find clinical trials and if you qualify. And Dr. Chen, feel free to chime in on this, but isn't it clinicaltrials.gov? Isn't that like one of the main sites?
Yeah.
Okay.
Yes. But I will say there are a number of different tools that are being generated out there. And because I hear about them, I've only tested one. I know, and I don't know if it's live on the website yet. So I apologize. I lose track a little bit in terms of whether they're available or not, whether in their testing phase still or not. But I know if you Google different clinical trial search, there are a number of different AI search engines that are being developed, and
nice.
it's probably worth investigating. And I have, because I know I had some clinical trials for pancreatic cancer, like the Pancreatic Cancer Alliance, I think is the name of that group. I think they have a tool to help patients find trials. And so that is being used. And maybe that's something the neuroendocrine tumor community can think about too.
Absolutely. Got it. And folks on my team on the back end, if there's any links that you can have that you can put in the comments for Rochelle, that would be awesome. We've got just a little more than 5 minutes left. We're going to try to get to as many questions as we can. Thank you so much, Dr. Chen. From Nat, is there anything that we can do post-PET scan to get rid of the radiation from our system more quickly?
Oh, yeah. Stay well hydrated. That's the advice we give for PRT patients with each cycle. And I would give the same recommendation for DOTA PET scans. And that goes with any PET scan, because your body is constantly trying to get rid of the radioactivity to begin with. And the kidneys are one of the primary organs that get rid of it. So if you stay well hydrated, that will help try to get rid of that.
It's funny. It's so simple, right? But you often overlook it or overthink it. Maybe it's a great point. Thanks, Nat. From Natalia, can red light therapy produce energy cells on the cancer cells as well?
Red light therapy?
Yeah, are you
Is that what you
familiar with
said?
that? Yeah.
Yeah. So a little bit. So you're
Yeah.
asking whether, because I know there are infrared type of treatments or photoacoustic imaging and photoacoustic therapies, as well as straight phototherapy. So I'm going to assume that that's what they're referring to. And I'm sorry, the question was whether
It was, can red light therapy produce energy cells, in quotes, on the cancer cells as well?
Actually cause cancer? Is that maybe the question?
I don't think so. It might be a little bit lost in translation, but Natalia, if you're there and you can give me a little bit of clarification, let me know. But I know red light therapy has gotten really popular recently.
Mm,
Um,
yeah.
but yeah, I don't quite follow.
Yeah. Apologies. Yeah, I'm
No,
not
no,
as familiar with red
no
light
worries. I'm
therapy
trying
or, oh, yeah, yeah.
to be a good messenger, but yeah,
Oh, no worries,
I'm
no worries. I'll just say I am familiar with some of the phototherapies, just what's been published in the literature and lots of preclinical data showing efficacy. I haven't seen any clinical trials, so I haven't kept up with the clinical trial development, and I am not aware of that as a major modality for neuroendocrine tumor, but it's definitely possible that there may be clinical trials on that.
got it. From Shane. Hey, Shane, what's your recommendation for assessing effectiveness of PRT as far as scanning protocol is concerned? So,
Mm.
scan after two, wait for it all to be done.
Yeah, we tend to wait until after all 4 cycles are done. And that is because when you give the PRRT, it can cause tumoral inflammation. And sometimes
Mm,
the tumors will look like they're getting bigger before they shrink. And so we used to get imaging after the second scan, but we saw enough, like most of them were like, uh, most of the tumors are either stable or had increased in size, and it didn't seem that helpful. So we just stopped doing that. We do SPECT CT scans after every cycle to assess how well the drug is going to all the different tumor sites. And sometimes we can see response or progression on those SPECT CT scans. And we found that that has been sufficient for monitoring, at least during treatment. And then we do formal restaging at 3 months after the last cycle to get our first look at how well the treatment worked. We know that you can still see responses even after that 3 months, but in discussing with other centers, most had observed, including our own, we used to do restaging scans at 1 month after the last cycle, and we found that was still a little too early. And sometimes you would see, mild progression when it really wasn't true mild progression. So, or true progression. So we've mostly settled on doing the first restaging scans at 3 months, and then depending on what that shows, then your oncologist will or your provider will just decide what that next follow-up scan protocol should be.
got it. Um, does from IRM does PRT affect male fertility, or do you know if been any studies?
Yeah, good question. Actually, I am not aware of any studies specifically looking at that. I don't think, like, if you just look at how the dotatate is distributed, it does not seem to have a very high uptake in the gonads, but we do know that it can lead to radiation exposure of the gonads when you look at the exposure, the dosimetry table. So certainly there's a radiation exposure, but I'm not aware of anyone that specifically looked at whether it has had an effect on male fertility.
Got it. Let's see. Oh, by the way, we just for Rochelle and others, we just put a link for ncf.net/clinical trials so that you can help locate some of those.
I guess let me make one more comment about
Please,
male
yeah,
fertility.
yeah.
So just, I think most of you may be aware of this, but with male fertility, the sperm are regenerated on a regular basis. So that's why when you get this treatment, if you wait a certain time after,
Mm,
it's in all likelihood, everything will have been regenerated. And so there should not be an increased risk. We worry more about ovaries because the number of eggs a woman has is basically set for life. And so those are not regenerated over time. And so we know from our thyroid cancer literature, when we look at radioactive iodine, we look more closely at the women, although there have been studies looking at both male and female fertility after radioactive iodine, and radioactive iodine has a much higher energy deposition than lutetium-177 does. And we do know that when you look at the rates of like birth defects or miscarriages, um, there doesn't on low level radioactive iodine, there doesn't seem to be an effect. With higher level radioactive iodine, there's a small signal, and so we tend to recommend, for women especially, to wait a year before they try to get pregnant and stuff. But because there's not a lot of data specifically with PRT. I know some practitioners have recommended egg preserving measures for women. We for men, I'm not as familiar with when they recommend sperm, banking and such. So, but that might be something on an individual level you could talk to your provider about. But I'm not aware of any like formal guidance with a lot of data to with solid data to support that guidance.
Any experience with histotripsy?
Very little.
Okay.
I know that I can't say much about it because
Okay.
I feel like, yeah, it's I just
Understood.
know it's out there, and I've heard that it's not working as well as we had hoped. But at
Uh,
the same time, it probably might help some patients, but
yeah.
that's all hearsay. So maybe I should
Well, we've
start
heard
with that.
similar. To
But
be fair, we've heard similar things on the show. It gets asked about it every week. So Donna, I was trying
yeah.
to get to you, but feel free to come back and ask next time. Lastly, I did get some clarification from Natalia. Red light
Mhm.
therapy stimulates mitochondria to increase ATP, cellular energy, which can promote healing in normal tissues. However, in tumors, increased ATP might enhance tumor growth,
Oh, I
cell
see.
survival, and growth, which is the concern. So I did.
Yeah. Oh, thank you. Yeah, thank you for clarifying. So I am not really sure. I mean, yeah, that would be a theoretical concern, but I am, in normal tissues, the energy, I'll just say this, the energetics in a cancer cell are different than normal tissues, which is why they grow faster to begin with, because they have higher glucose utilization rates or other metabolic rates that are higher than normal cells. So you're already starting with a cancer cell that has a highly efficient energy utilization mechanism, enabling it to grow and, grow amidst other normal cells. So I I'll just comment on that. I would say that my guess then would be that the red light, it might be hard to measure a change in the energetics if the cancer cell is already optimizing its use of energy. But it is an open question, so I don't really have any data, just that hypothesis. But I think it's something that could be tested.
Sure. Well, folks, that is our show for today. Dr. Chen, thank you so much for being here. Your first time.
Yeah, no, thank you for having me. This was fun. And it's always great to get these questions. I mean, I think about stuff from my, physician perspective, but like I learn a lot from talking to our patients, and it's really, I mean, I really enjoy these forums. So thank you so much for
Yeah.
having me.
And it's I love that you had said something earlier about someone's question made you think about something differently. That happens all the time too. And part of what I love, it's not just one way communication. It's
Mhm.
very much this kind of symbiotic relationship or something, right? It's like
Yeah.
it goes back to that community aspect we talked about in the
Yep.
beginning. So I love to see
Yes.
that. So we appreciate you being here so much. And for you all at home, we appreciate you as well. We hope this program helped answer some of your questions. We're back every 2 weeks this year. And I'll reiterate the new link is ncf.net/support line if you have any questions in the meantime. Thanks again to our presenting sponsors. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy.